BWHS participants, you are a very special group of women. Next slide, please. My name is Lynn Rosenberg. I'm one of the 3 founders and leaders of the Black Women's Health Study. I'll be giving you some history of the BWHS before handing over to Julie Palmer. We don't have Lucille Adams Campbell with us today, but we're hoping that she will be part of a seminar in the series. Next slide, please. We have a wonderful advisory board. We're very fortunate to have today with us Dr. Alicia Georges, who is on the top right. She has headed a nursing program in New York for many years. She's headed the Black Nurses Association and has been the leader of the American Association of Retired Persons. We also have Dr. Ellen Grant joining us. She is a psychologist, a healthcare administrator, a government official, and best of all, she is a Black Women's Health Study participant. Just to tell you about some of the other members of the board, Drs. Bernstein and Hankinson are cancer epidemiologists. Dr. Kumanika is a world expert on nutrition. Jackie McLeod runs a foundation to help individuals released from prison to re-enter society. Next slide, please. This cartoon shows the state of medical research when I entered the field in the 1970s. Research was largely about white men. So as this woman says, "Doctor, what's wrong with me?" He says, "You're not a white male." Well, in the 20 years after this cartoon, there were more studies of women, but it turned out they were studies of white women. Next slide, please. So as I and my colleagues were discussing what kind of study is needed, it became obvious to us that a study of Black women was needed. Rates of death from heart disease, stroke, cancer were higher in Black women than white women. Especially glaring was the higher rate of breast cancer death in Black women than in white women, due mainly to an aggressive breast cancer subtype that was disproportionately affecting Black women. So we wrote a grant proposal, and after several tries, we got funded by the National Institutes of Health. Next slide, please. We began the BWHS by mailing invitations and questionnaires to over 400,000 subscribers to Essence Magazine. We also mailed to the Black Nurses Association members and to friends and relatives of early respondents. The 59,000 Black women who said, yes, we'll answer questionnaires, yes, we'll be followed, and they did complete a 16-page questionnaire. They have been members of the Black Women's Health Study since it began in 1995. And response rates have been very, very high. Next slide, please. The cohort was young at the beginning. The average age was 38. And this young cohort made it possible for us to study these aggressive forms of breast cancer that affect younger women. Now, 25 years later, the average age is about 63, which makes this cohort a very, very suitable cohort for studying aspects of factors that affect aging and cognition. As you can see in this picture of a geographic region, participants are from around the country and with a range of educations from high school through beyond college. Next slide, please. Most of the participants in 1995 came from these states that are in dark green. So from the West, the Midwest, the Northeast, the Southeast, and the South. Now participants at the present time live in 49 states and 9 foreign countries. And now I would like to hand over to Julie Palmer, who will tell us about some of the accomplishments of the Black Women's Health Study.
It's a real pleasure to be here, and I would just like to say that I was sitting here listening to Lynn, and it's amazing to one person after another say, I'm from here, I'm from here. I've been in the study since the beginning. It's such a feeling of community. On this slide, you'll see a very familiar image, one of the many questionnaires you've received. And new questionnaires are available either by mail or online. And currently about half of participants choose the online option. And the questionnaires ask about factors that then some of the same questions asked over and over because habits do change over time. The questionnaires also ask about illness and medication use. Next slide, please. We obtain additional information aside from the questionnaires from linking with various databases. For example, we link participant addresses with data from the Environmental Protection Agency, and in this way we can get information on air pollution and other toxins and see if they're related to health. Next slide, please. BWHS participants have been incredibly generous in providing biologic samples that can enhance the research in the Black Women's Health Study. So early on, about half of all participants gave a saliva sample by swishing with mouthwash. And these samples have been used for genetic research related to many different conditions. More recently, about a quarter of participants have provided a blood sample. And blood samples are used for hormone levels, lipid levels, vitamin D, all sorts of biomarkers that can be studied in relation to heart disease, stroke, cancer, and other conditions. For women who report cancers, we attempt to get the tumor tissue that's stored at hospitals where the surgery took place, and looking at the tumor tissue can tell more about the exact cancer, which will help to learn about both prevention and better treatments. And finally, we've reached out to many of you to ask permission to obtain your digital mammograms. And you can see here the number of people who have already provided that information. And this information will be used for understanding better in what way mammographic density and other features of what is read from a mammogram is related to breast cancer risk in Black women. Next slide, please. This slide lists the many conditions that we've studied over the years. You can see both cancer and non-cancer conditions. And in the and almost all of these conditions are more common in Black women than white women. And that's why we've chosen to study them. And most of them are pretty serious conditions. In the early years, we focused on health issues that are more common in younger women, such as preterm birth and fibroids and breast cancer. And now we're moving to many other diseases. We've published more on breast cancer than any other cancer just because of the young age. And I'm going to tell you about a couple of our findings now. Next slide, please. As you know, we ask about patterns of physical activity on just about every questionnaire. And we've grouped participants according to how often they participate in vigorous activity, such as running or aerobics, and ranging from almost none to once a day. As you can see from the figure on the left, as there's more physical activity going with that line moving to the right and the line going down, that shows that the ones who exercise the most have the lowest chances of getting breast cancer. And it turns out it wasn't necessary to do running or something really vigorous. We looked at walking habits and found that women who do a brisk walk at least 3 to 5 times a week also have a reduced risk of breast cancer. And that's one of our aims in the study, is to identify modifiable factors that can make a difference, something that most people can do that will influence their health. Next slide, please. Risk prediction models can be used to predict which women are at high risk of developing breast cancer. And then these women can be offered screening such as mammograms. even if they're below the usual age for mammograms. The currently available breast cancer risk prediction models have been used in white women for over 20 years, but they don't work very well for predicting breast cancer in Black women. Now, why is that? Well, those models were developed in data from white women, and that didn't take into account the different patterns and the risk factors in Black women. So 6 years ago, we developed a new model based on BWHS data. It was better, but not good enough. We recently received NIH funding to develop a new model using an approach that takes into account the different risk factors for the two major subtypes of breast cancer. One of those subtypes, which is called estrogen receptor negative, is twice as common in Black women as in white women or other groups of women in the US. It occurs at younger ages, and it tends to be more aggressive. It's our hope that the new risk prediction model will lead to earlier detection of breast cancers and fewer deaths from breast cancer among young Black women. Next slide, please. Finally, I'd like to talk a little bit about type 2 diabetes, also known as adult onset diabetes. This is a common condition. It's becoming more and more common, and it carries a lot of serious health, leads to a lot of serious health problems. We evaluated different aspects of the diet. You may remember a couple times filling out a very long food frequency questionnaire. So one of the factors we looked at in the diet was what's called cereal fiber. And those are foods like whole wheat bread or whole wheat pasta or oatmeal that carry a lot of fiber, of the grain type of fiber. And we classify women according to very little, medium amount, or eating a appreciable amount every day. And we found that women who ate the most fiber had a clear reduction in risk of developing type diabetes. And this, again, is something that's very doable. Switching in or substituting a whole grain food for something that isn't is a way to reduce the risk. And, this took everything else into account. So people who were similar on physical activity, weight, and yet if they ate whole grain foods, they had a reduced risk. And now I'd like to introduce my colleague, Dr. Yvette Kozier, who's been an investigator on the BWHS since just about the beginning. Dr. Kozier?
Thank you, Dr. Palmer. Good afternoon. It's so nice to see everyone here. I'm looking at the chats as everyone is coming on. I'm going to talk a little bit about some of the other studies we've done in the Black Women's Health Study. So although racism has recently been prominent in our public discourse, the Black Women's Health Study has been studying this topic in relation to numerous health conditions since 1997. These conditions include preterm birth, uterine fibroids, asthma, and type 2 diabetes. Here I present data on an analysis exploring the influence of perceived racism on developing obesity. Obesity, which is essentially the ratio of one's one's weight to one's height, can predispose individuals to many health conditions. Therefore, it's important to explore the many factors which may contribute to its development in Black women. We asked women about their lifetime experiences of racism, experience on being hired or fired, in obtaining housing, and in encounters with law enforcement, as well as everyday interpersonal experiences that it may have involved receiving poor service than others or being treated as being dishonest. Compared to women reporting few or none of these experiences, women with more frequent experiences were more likely to become obese over the 12-year period. We found within the same analysis that residing in a segregated neighborhood, particularly those that had poorer resources, also contributed to becoming obese during this time period. So it gives an added dimension of how place plays a role in our health as well. Next slide, please. So using a similar set of measures, we've explored the relationship between racial discrimination and insomnia, a topic of interest among our Black Women Health Study participants. Like obesity, insomnia and poor sleep patterns are associated with numerous health conditions. Similar to the previous study on obesity, we see that higher frequency of experiencing racial discrimination in any of its forms resulted in greater likelihood of experiencing insomnia or disrupted sleep. Next slide, please. Finally, a recent analysis found recent analysis of racism and subjective cognitive function or memory loss. We found that women who experienced frequent racism, again in any form, had greater memory decline. This is important as rates of dementia and Alzheimer's disease are higher in African Americans than white people, and certainly among women, African American women versus white women. So this may be one of the factors that contribute to this disparity. Next slide, please. So COVID-19, as we all know, has had global effects, but in the US, African Americans bear a disproportionate burden of infection, hospitalization, and mortality. Many of these disparities are rooted in social determinants, which impact Black women in particular. Next slide, please. So some of these determinants are that in the United States, African American women are more likely than white or any other ethnic and racial group to serve as the economic breadwinners of their households, to hold jobs on the front line where commuting and working remotely are not an option, so they remain at higher risk of infection. They often, Black women more than any other group, will live in lower socioeconomic neighborhoods, lower resourced neighborhoods, regardless of their individual levels of income or education. We also live in, more likely to live in multi-generational households. And as the previous slides showed, we have frequent and chronic experiences of racial bias at all levels of society. So in response to the inquiries of participants, as well as the need to look into these disparities, we've begun a new online study within the Black Women's Health Study to explore the role of COVID, both in terms of risk of infection and on long-term health, including cardiovascular disease. And we will talk more about this coming up. Next slide, please. So in addition to COVID and cognitive function, we are exploring many additional research areas, many based on participant suggestion. As these studies get underway, we will reach out to solicit participation on a number of these conditions. Next slide, please. So in order for us to maintain high rates of follow-up, which we have done over the last 25 years, we have a dedicated staff who reach out to participants, interviews for those who can't or choose not to complete the questionnaire on paper. We offer phone calls. We have the questionnaire online. We also have a Facebook page. We send newsletters twice a year to update the population on our research activities. We also have a participant advisory group. This is a group of participants who kindly offer their time to preview questionnaires and other items that we are considering sharing with the BWHS community. So if you have any interest in working with us, collaborating us as a participant advisory group member, please reach out to us. Next slide, please. Finally, we've had a very busy and productive 25 years with the overall study and with important sub-studies. So we look forward to many more years of working together to improve the health of Black women. And from here, you can see that we've incorporated quite a few things over the years, and we will be reaching out as other studies become underway. Next slide, please. Finally, I'd like to remind you about the next installment in our anniversary webinar series. On Thursday, November 5th at 3 p.m., we will be discussing COVID-19 within the Black Women's Health Study. Information can be found on our website. Also, if we don't have a current email on record, please contact us so that we can notify you about this in future webinars. Email is a very easy way to get in touch with you. So next slide, please. So at this time, I want to first thank all of you for the questions that have been submitted in advance and so far this afternoon. We will do our best to answer as many in the time allotted. Also, to note that the first 5 minutes of Facebook, we had some streaming difficulties, but the entire program this afternoon is being recorded. So you can come to our website to make a copy and see what little was missed in the first 5 minutes. But at this time, I would like to invite Dr. Ellen Grant and Dr. Alicia Georges to join our discussion this afternoon and to start to answer some of our participant questions. The first question is anyone surprised by the commitment the study participants have exhibited over all of the years? And I'd like to ask Dr. Georges to respond to that question.
Thank you, Dr. Kozier. It's wonderful to be celebrating this 25th anniversary with you and Dr. Rosenberg and Dr. Palmer and my colleague, Dr. Grant. I was there in the beginning and with Cordelia Russell. I was there in the beginning with Lynn and Julie and Lucille Adams Campbell. What a wonderful, wonderful, awesome study. I'm not surprised. Why should I be surprised? This study connected people to who they are, what they need to be doing for themselves, and what would be the outcome if they listened and they followed some of the directions, read the studies. But most important, I think, for a person's self-efficacy and confidence is that they're part of something that's going to make a difference, not just in their lives, but it's going to make a difference in the science, and that will have a long-lasting effect on others to come.
Thank you. Thank you so much. Another question here is, how do those who are mostly isolated during the pandemic stay mentally and physically healthy? And I'd like to send this question to Dr. Grant.
Thank you, Dr. Kozier. It really is a pleasure to be here. I've been with the study since the beginning also, first reading about it in Essence magazine. And what I almost jumped out of my chair because at the time I was Commissioner of Mental Health. And I was very concerned that there are all these studies, again, going back to Dr. Rosenberg's cartoon with about, being not being a white man. Black women were even less visible. So, this study made us visible in the community of research. So thank you, a million thanks for that. But in terms of what can people do during this pandemic to stay mentally and physically healthy? Well, you brought up one point, Dr. Kozier, in your study about movement. If you can't run, you can walk. If you can't walk, you can sit in your chair, you can move your legs up and down in a marching effect, or from side to side. Also, swinging your arms. That's something physical you can do, especially if you have limited mobility. I also think that we know already that social isolation can be very impactful on someone's emotional health. So it's very important for you to stay connected with someone in your community. If you don't have relatives or close friends, it's important for you to see what's going on in your community with a lot of the community, like senior centers and similar community functions that are now starting to open up and are making allowances for reaching out to people that are socially isolated and in their home, okay? So I hope folks would do that. Now libraries are starting to reach out. If you don't want to leave your house, a lot of libraries are starting book clubs where you're calling into a phone number and having a collective community reviewing books. So those are just a couple of the examples.
Thank you. Thank you very much. Another question. Will the study address our aging process and the health of elder Black women? Dr. Rosenberg, would you like to answer or respond to that question?
Right, it certainly will, and we've actually already begun. So we're studying illnesses like incontinence, which are more common at older ages. But I think what people worry about the most as they get older is losing cognitive function and perhaps developing Alzheimer's disease. So we have actually just gotten a grant to study racism in relation to Alzheimer's disease. Racism is a stressor. And stressors have been shown to cause inflammation, and they affect areas of the brain that are involved in memory. So it would be expected that people who have experienced a lot of racism might have lower cognitive function for that reason. So we want to study the effect of racism, but just as important, we want to study factors that can work against this kind of stressor. So we want to study the effect of exercise on cognition and developing Alzheimer's disease. We want to study what a healthy diet does. We want to know whether we can demonstrate that having a supportive community helps people's cognition. So we are going to devote a great deal of energy in the coming years to studying Alzheimer's disease.
Yeah.
Thank you.
Can I also add that, you know, I really am concerned about the emotional stress that this pandemic is causing. There was a government study that said that 3 in 5 people are concerned about getting the COVID. And the other concern that I have with all this talk about getting a vaccine, that there aren't enough people of color that are volunteering, that are included in the study to see the impact of COVID and all the issues that may surround it. So I'm hoping that we can play a role in that regard.
Yes, no, thank you. You bring up a really good point. And so as I mentioned during part of my presentation, that we have begun a study of COVID, both perceptions and perhaps risk factors, but also for those women who have been unfortunate and contracted COVID to learn about their recovery and their time going forward with that. So we will take this up as a topic at our next webinar. So Ellen, I would love for you to join us there, and I hope that many of our participants also will come back and be a part of that deeper conversation where we can really focus in on what we're learning about vaccination, and there's a lot of anxiety about that, as you mentioned. There's not a lot of information coming out that make people feel very secure around that topic. So I'm looking at another question here. What are some of the most important discoveries from the 25 years of research? Dr. Palmer, are you on? Would you like to?
I am, and I want to apologize. I've lost my video, but after this question, I'm going to try logging out and logging back in. But I hope you can hear me.
Yeah.
So yeah, Yvette, some of what I know a lot of people have asked that question, and we ask that question to ourselves quite often. You know, we're doing all this work, but what's really coming out of it, what's going to make a difference? Because of course, we really want to make a difference for the individual, for the, you know, health policy, for clinical practice. And some of what we showed in those slides were some of our findings that we think are among the most important. A couple others that I'd like to mention. One thing that's, I think, very important that was learned from this study, and this is regarding breast cancer again, and this worst subtype called estrogen receptor negative. And about 1/3 of all breast cancers in Black women are that type. We learn from analyzing the data that women who breastfeed their babies, or at least one of their babies, have a lower risk of getting breast cancer and of that type of breast cancer. no one knows the exact reason, but it probably has something to do with um, inflammation that happens around the time of childbirth. And if someone breastfeeds and there's a slow process of then stopping breastfeeding over a few months or 6 to 12 months, that the inflammation doesn't have a bad effect. So this isn't going to be helpful for women who've already finished their childbearing, but it will be helpful for the younger women, the women still to come, to know about that breastfeeding isn't just good for the infant, it's also good for the mother. And because this type of breast cancer, estrogen receptor negative, doesn't have many factors that we know about, it's not the same thing as the other type where you can be sure not to take hormones and to lose weight, where that may make a difference. We don't have many factors for this type. So we consider that a really important finding, and it's now accepted in the scientific community. And I know that there have been efforts being made, particularly within the Black community, to pass this message along. So that's one thing. And then on the other level, we've found through our research, we've been able to show that place matters. Where you live matters over and above what you do yourself. And Yvette, you've done a lot of this research. Would you like to comment on that?
Sure. So as I'd mentioned before, even looking at the risk factors for COVID, African American women, regardless of our education and our income levels, we are more likely than any other racial group to live in a neighborhood that maybe does not reflect us fully, doesn't give us the full range of amenities that are useful for our health. We often have to get in a car and drive elsewhere to get certain services rather than being able to walk to or be much more closely situated. All of these things over time can impact our health in big and small ways. One certainly is how close we are to a full service grocery store within our own community. And that's nice if you're able to get into a car and drive a few miles over to another community that has the full service thing. But again, that's expending a resource, and we're sitting down in the car getting there. We were talking about exercise. Dr. Grant, you were mentioning physical activity, and we've shown how that affects our health in positive ways. If there are, if we lack places for outdoor physical activity or other forms of physical activity, that also affects our health over time. So we have been able to look within the study at a number of these of neighborhood on risk of hypertension, risk of obesity, as I mentioned, and other things such as even breastfeeding and tooth loss. So thank you, Dr. Palmer. There was one thing that Dr. Grant said that I'd like to, I had to write this down around the impact of the study, is that this study made us visible in the community of research. And I think that is very something to keep in mind. Prior to this, we were completely invisible, but we are at least minimally visible there. So there's another question, and I might field this one myself, but it's how long is the research going to continue? So I did see also coming through the chat that someone said this study was supposed to just be 5 years, and here we are celebrating 25 years. We would love this study to continue for as long as we can continue to receive funding and continue to have your enthusiastic support of the study. I think we can all agree that the complexities of our lives and the things that contribute to our health cannot be learned in very short periods of time. It's really over the length of time. And when we look at the big studies of white men and women, they go on for decades. So that we've continued to get funding and continued to have your support has been remarkable. So we would love the study to go on for as long as possible. Another question is, can new people join, and how many participants are still continuing? So the way the study was established is we are what we call a fixed cohort study. So the same group of women that we began with in 1995, we've been continuing with. And over time, participants numbers may decline. So we began with 59,000 and we are at approximately 49,000 women. So this includes women who have unfortunately are now deceased over the 25-year period, and others who may be lost or may be taking a break from us. But we have, we don't usually bring in new people. We are staying with the same group of women that we began with. With that, I'd like to move on. Dr. Georges, what would you consider to be one of the greatest successes of the Black Women's Health Study, sort of following up on Dr. Palmer's response, but what would you consider to be a great success, and how has this research actually really benefited Black women? Oh, you're muted, Alicia.
I firmly believe being in higher education and in a health professional program and having intersecting with a number of primary care providers, researchers, practitioners, that the work, the scholarship that has emerged from this study has been critical for the way practitioners have begun to practice and educate Black women. It is interesting that we talk around things and on the edges of issues, but this study has been right up front in clearly stating what the issues are. Racism, no question. Stressors, no question. Zip codes, no question. Where people get food or don't get food, but the critical piece is that it removed itself. We studied for so much, these poor people, they're so, this was a different kind of study. The cohort itself is so different. And because of that, we have a low attrition rate. I wish some of the long-term studies had the attrition rate that we have. That's an excellent that people have maintained and retained in this study. But really in the dissemination of the information that has emerged from these research studies. I know it's secondary data analysis, but it is critical. It is critical. And I push my doctoral students, my graduate students to make sure they utilize this information. It makes a difference in practice, Dr. Kosher, Dr. Palmer, Dr. Rosenberg. It makes a difference if the direct practitioners utilize the science that exists. And then, you know what? And then we can change. We can do, as I say, upstream, we can begin to change things so we don't see it downstream. Interventions early on will make a difference later on and reduce the chronicity, because along with chronic illness is the chronicity of racism. And we want to try to figure out how we can, disperse that and make things better for our participants.
Yes, thank you. Thank you so much. So you mentioned the scholarship that emerged from this study. Dr. Palmer, how do we communicate study results? Some participants would like to know.
That's a good question. There are several ways. When we have a finding, we write it up in the format of a scientific manuscript or paper, and we submit it to be published in either a public health journal or medical journal or scientific journal. And that way, before it gets published, it gets checked by other scientists who have no association with us, and that's called peer review, to really make sure it's a, very well done analysis. We don't want to publish something that's, got some mistake we didn't notice. So our aim is first to publish these things in this way, and then have that trickle down to the appropriate types of people. So sometimes it's an initial finding that we think is mostly important to get out there so other researchers see it, and they then will try to see if they have the same findings in their data or sort of go further that. Sometimes we have a finding that we think is of immediate clinical importance or public health importance. And those we try to publish in a higher profile journal and one that's read by healthcare practitioners. And often for those types of publications, there's some media interest. So then we'll take the time to talk with the news media, either, a lot of times it's through emails and they have online reports, or sometimes it's actually in the print press, or we do radio shows. We do a lot of Black radio. We're on different Black radio shows to report on results. I remember doing that for some of our diabetes results. Sometimes we're interviewed for television. So we'll only do that if we feel pretty certain about the results and we want to, get this out to as many people as possible. We also attend scientific conferences so that we can speak to other researchers and other clinicians. So some of the conferences we go to are specialists. Yvette has gone to a number of conferences of both thoracic doctors who do a lot of work on sarcoidosis, which is one of the diseases she studied. We also go to rheumatology conferences because we're studying lupus. I go to conferences of oncologists to report on cancer. So we want to sometimes speak directly to the physicians, sometimes we're speaking to other researchers. And then, as you know, we want to give results directly to study participants and the wider community of Black women. And we do that through the newsletter, and I've seen a few comments here already where people like the newsletter. And we also do it with our Facebook page, which is open to more people, and we try to put information up there, as well as our BWHS website. Because on the website, we do have lists of all of our publications, and Dr. Rosenberg writes a few sentences about each one to describe very briefly what the results are.
Yep, exactly. And you can see some of those write-ups also on our website, as was mentioned. So Dr. Rosenberg, so you talked a bit about the study with dementia or Alzheimer's disease. Can you tell a little bit more about the sleep study and where people can find results?
Yes. So the sleep study, the insomnia study, is an example of sort of the interaction that goes on between the investigators and the participants. For a long time, there were participants saying to us, please study insomnia, please study sleep problems. And we thought about it and we did a little research and we discovered that there was a literature showing that Black women have more insomnia than white women. And so we then met some colleagues. We spent our time finding colleagues who would know something about insomnia, and we found the appropriate colleagues, and we decided that we were going to do a randomized trial of the treatments for insomnia, because to get treated for insomnia, you need to go to a trained practitioner, who are very rare and they're hard to find and they're expensive, and you might have to go for 6 or 7 sessions and learn about how to have good sleep habits and so on, so you won't have insomnia anymore. So we found some colleagues who knew about a treatment for insomnia that's actually online, and we got funding to do this study, and we enrolled. We invited participants. We started out by putting a questionnaire, 7 questions about how you sleep. And scoring this 7-question questionnaire gives a sense of the people who have insomnia and the people who don't. And when we got funding to do this online study of insomnia, we were going to enroll 300 participants, one group in standard treatment, one in a online treatment called Shut-Eye, and one in an online treatment in which we had modified Shut-Eye, especially for Black women. And our colleagues are absolutely astounded because they've done studies of this program, and in order to get 300 participants, they had to ask something like 3,000 or 4,000 or 5,000 participants. In the Black Women's Health Study, we wrote to 1,000 participants, and we got our 300 participants who are in the study. Then when we start looking at how people have adhered to their treatments to which they were assigned, our colleagues are once again astounded because there are so few dropouts. So we are studying insomnia, and as soon as we have results, which will probably be in about within a year anyway, we will be able to let people know about an online program that they could take on the internet that might help them treat their own insomnia.
Thank you. Thanks. So just a couple of quick questions that are in the chat or the Q&A. One is about hair loss and alopecia. Throwing back to you again, Lynn, if you want to address that, and
Right.
also Julie. Mm-hmm.
Black women are more subject to a type of hair loss than other people. It's called central scalp hair loss. And the reasons for it are still unknown. It had been suspected that perhaps diabetes is involved. So we got the collaboration of an African-American physician who specializes in hair loss. She's a dermatologist, Dr. Lindsay. And she helped us develop a questionnaire that we sent to participants online. So this was an extra study that people could participate in if they were interested. And I think about 6,000 or 7,000 women completed this questionnaire, which had pictures of hair loss, which they could pick the picture that most accurately showed their own hair loss. And we had information that we've collected over the years on diabetes and a whole range of other conditions. And when we did the analyses, it turned out that yes, diabetes was very strongly related to this type of hair loss. So this is really the most instructive study of this type of hair loss that has been done. Dr. Lindsay thinks that people should come into their dermatologist and see what treatment they could get. There is really not a specific treatment that is suggested, but dermatologists have different ideas about what they can try.
Thank you. Another question is, Alicia, earlier you were mentioning food deserts. Would you like to just speak a little bit more broadly about what that is and how that might affect health? And you're muted, Alicia.
I live in New York City in the Bronx. And I will say to you that in those neighborhoods, and again, looking at zip codes, as you indicated earlier, where people live, there are stores that do not have those kinds of things that we know, like the increased fiber type cereals, fresh produce, fruits and vegetables, or have no supermarket. It's interesting that I think that I'm pretty okay socioeconomically. For 10 years, there was no supermarket in my community. I mean, I did have a car and I could drive. But the issue is that those who cannot get to those appropriate kinds of grocery stores where they would be able to have it. Back about 2 years ago, a group of students at my college went in, they found the grocery stores, but then they also looked at the flyers that came out of those grocery stores, encouraging people to come. There was no mention of fruits or vegetables. It was all crackers, you know, really quick food. You can add hot water to, high in sodium, you know, with little or no nutrition value. And that's been a big concern to many of us in communities. I will tell you, there is some positive things that are going on. Many of our healthcare, at least in my borough, many of our healthcare systems have green grocers outside their hospitals, because we're in the borough that has the worst health indices in the state of New York. So they've had, you know, green grocers, and on pressure from people in the community and looking at the science, our cities have begun to establish farmers markets, particularly in the summer and in the fall. We haven't done anything since COVID, but it was something that was a really great intervention. But food deserts exist all across this country, not just in urban areas. People in rural areas who don't have access to the stores where they can purchase things. People think if you live in farmland, you got lots of produce. That's not true anymore. You know, there's some of the poorest communities across the country and no access.
Yes, thank you. Dr. I'm sorry.
I just want to intercede here because I just saw a really interesting question that Julie
Sure.
Palmer could answer, because she's just published on this. And the question was, does the BRCA gene operate among Black women? And I thought that was something, this is one of the breast cancer genes that causes women to be at extremely high risk if they have that gene. And Julie has just published a very important paper on that in Black women.
Thanks, Lynn. Yes, I'm glad to have the chance to share that. And the paper just came out maybe 4 or 5 months ago, and it's mentioned on our website. And it did receive a lot of attention because until now, no one really knew the answer to that question. And in fact, a lot of doctors who saw women with breast cancer the first time didn't know whether to refer Black women with breast cancer for that type of genetic testing, because some of them felt, well, you know, what we have on BRCA1 or a few of the other genes that are really strongly associated with the breast cancer, we don't know that that works the same way in Black women. All the research came out of white women. As a result, many fewer Black women with breast cancer and their family members have been suggested to go for that kind of genetic screening. So the BRCA1 gene, having that bad variant is very, very rare in any population. So in order to have meaningful research, you need big numbers. So it was only now with the Black Women's Health Study and a few other studies, we were able to combine our information together and join with someone who was taking either blood or saliva samples and doing this kind of sequencing for us, that we ended up with, among our few studies together, 5,000 women with breast cancer, 5,000 comparable women without breast cancer. It was enough to see whether the associations are the same. And we found that for the 3 genes that are most strongly related to breast cancer, which is BRCA1, BRCA2, and then one you probably haven't heard of, I hadn't until a year or 2 ago, PALB2, all of those increase the risk 7 or 8 times. They're all very important genes, and we found the same associations were present in Black women as in white women. And when I wrote the paper, I did it with the angle of, you know, the importance of it is for the practitioners. This is to, you know, tell you that now you should be having that first in your mind when you're seeing someone who either she herself has been diagnosed with breast cancer or she has a close relative who has breast cancer. And when it was published, the journal asked for an editorial to go with it. And the woman who wrote it was thinking along the same lines. So I think that will have an impact on practice going forward. So the answer is yes, it is the same. And now, since I have the floor, I'd like to answer another question that I saw coming up through the Q&A section. Someone wrote in at 3:44, I have been very apprehensive about sharing samples that have been requested for fear of my results getting in the hands of the wrong people. Please give information on how you secure that information. Thank you for that question, because that's something we've been thinking about for the last 15 to 20 years since we first asked for saliva samples. And it's an ongoing discussion on how best to protect that information and at the same time have research go on in Black women, because we do want the research to happen. We don't want Black women to be excluded from the research, but we don't want it to be used by the wrong people, as has happened in the past. So there are a couple things we've done. First of all, everyone has had a chance to say yes or no to giving their samples. And if they say yes, there's a written informed consent that describes some of the procedures and what will happen, so they can see that and sign it. And we abide by that. And our institutional review board is very, watching over everything. They kind of make sure we do. But what we're doing on an ongoing basis is being very careful about how the results are used. So when some sort of assay is done on these samples, and especially when it's a genetic result, those results are kept in a very locked computer file. We will only share that information in a way that it's not connected to anything that might identify a person, an individual person. So if, for example, when I sent these samples to have this assay, which I call sequencing, they went with a fake ID number. That's not even the same as the ID number used in the Black Women's Health Study. Only somebody who works for us had the key to that ID. It went without any names, without a date of birth, without a zip code, anything that could be used to identify that person. In addition to that, we don't want people, besides the issue of whether they could know whose results it is, we also don't want harm to the entire Black community through misuse of this information, which, as you know, can happen with all sorts of information, including genetic information. So we don't share this information except under very certain circumstances where we have reviewed who will be using it and what is the reason. And then we always have the final say over what can be published, so that we can look and see whatever is going to come out and make sure they aren't making these claims that would harm the population. And finally, those of you who did give a blood sample, on the consent form, it had when you got to the end and you signed the consent, you also had an option to say yes to allowing results from your sample to be shared with on a US database that then is unidentified, but other people can use the data for research. And some of you said yes, about 65% said yes, and the other 35% said no. And that's fine either way, and we abide by that. So your results, all 100%, have been used for our own analyses. But when we send data to this very carefully guarded database, which the NIH more and more requires us to do because they want the most research to be done, we will only send it for the 65% of people who said yes to that purpose. I don't want to use up all the time, but we're happy to discuss that more in the future too.
No,
important.
thank you so much, Julie, for responding to that question. I want to throw one to Dr. Grant before we get ready to wrap up, but there was a question about mental health effects on insomnia. So we've talked about insomnia, and we began with your discussion around mental health. Can you share some insight on that relationship?
Well, there definitely is a relationship. I mean, the fact that, you know, we're in a pandemic and depending on what's going on in your environment, the racism issues, the everyday microaggressions you may be feeling. But you're talking about mental health in relationship to insomnia. Was that the question?
Yeah. What are are there mental stressors? Yeah.
Sure, and I saw a lot of great suggestions down here already that, you know, you all are the experts, you're doing it. Meditation, sleepy time, herbal teas, exercise, so that your body gets tired enough. And just turning off the TV. Please, people, there's too much negativity in the news right now. I saw somebody saying they're staying up and watching all this political stuff. That is not good for your brain. So a lot of spirituality, deep breathing, reading the Bible if you're religious, going to prayer groups. I saw somebody doing prayer walks in a group. So just some quick ideas to share.
Thank you. So we're just about, we're just a little over, but I want to just throw one final question out to the entire group. And that is, will there ever be a way for our daughters in the next generation to participate in future studies of Black women? So anyone can respond to that.
If we
Again?
can find a willing funder, a philanthropist, not just NIH, but somebody who sees the merit and have looked at the outcomes from this study. So I like to call them investors in the future of a healthy America. So if we can find somebody like that, we're on target.
I'm thinking Oprah, and I'm thinking Mr. Turner, and some of the other folks out there that can help us with, even Gates, the Gates folks Foundation. So I would be happy to be part of a collective group to reach out to that group of people to say we need to keep this going, because this really is a lifeline if we're going to get to the point where we can look at equity in research between people of color.
You can see we've all gotten older, just as the participants have, and we want the younger researchers to take this on. And there are more and more now young Black epidemiologists and other researchers who have so many different specialties, who could really get going a great study, and we would love to help them. But as Alicia says, we need funding. This study, and I saw a question in the chat, has been mostly funded by the National Institutes of Health. Well, they don't have that kind of money these days to start a new study. We need those other big funders. It needs to be done. I've seen so many people write in, what about our daughters? What about our granddaughters?
Dr. Rosenberg, would you like the last word on that? Oh, you're muted.
Not really, Yvette.
Okay.
I have to agree with Julie that this is really something for the new generation of young investigators. And we actually have a few young investigators who are joining us, and we think they might be part of the wave of the future. But it is for the younger investigators to take on.
Great. Well, with that, I want to just take a moment to thank everyone. Don't go away yet, but I want to thank everyone for joining us today. This is the first of a series of these planned webinars. The next, again, will be on Thursday, November 5th at 3 p.m. and the topic will be COVID-19. So please join us. Please stay in touch. Make sure that your information, your contact information is up to date so that we can send you reminders, or you can come to our website and check to get the registration details. I want to say a quick thank you to Delia, Maria, Renee, Yvonne, Shan, Kim, Lauren, Hannah, and Jessica, and anyone else that I've missed from BWHS staff who've helped us to pull this together, Meredith Brown,